Hope you guys are doing fine, fabulous and fantastic. This is Dr. S. Krishna Kumar here. We are in for a very new type of recording which is different from the conventional type of recording. What is conventional MCQ recording discussion, sir? We have a clinical case scenario. We will have 4 options below and you have to choose any one of them. But here, what are we going to try now? I'll just put only the clinical case scenario. 4 options won't be there. I repeat, 4 options won't be there. It's an open-ended discussion where we can discuss numerous possibilities. Why to restrict ourselves to 4 options when the scope for discussion is wide? That is the basic theme of this discussion. The clinical scenario will be there. I'll be able to tell you here what are the possible MCQs from this, but 4 options won't be there. It's an open-ended discussion. If you see the first MCQ, you yourself will understand. With this important introductory note, and we are going to have a discussion. What is about here? It is about the physiopathology. Usually what we have is the pathophysiology, but here in this clinical physiology MCQ discussion, I will first tell you the physio component, then we will discuss about the pathological aspect. Let's look into the first MCQ, guys. What is the first MCQ? A 22-year-old female admitted with complaints of passing blood instead of urine in the early morning. Passing blood instead of urine in the early morning. And for your information, this is going to be the most common complaint the patient tells you in this disorder. What is that? Passing blood instead of urine in the early morning. She also had recurrent attacks of severe abdominal pain. Lab investigations revealed anemia, neutropenia, thrombocytopenia. Elevated LDH levels. USG of abdomen showed the thrombosis involving inferior vena cava. Flow cytometry was ordered. There are no 4 options here. You don't have to choose anything. Just simply sit back and listen to this discussion. What are the possible MCQs? But before that, what is actually this disorder? Yes, tell me. I'm hearing it from you. Yes, guys, tell me. What is that? Yeah, PNH. Can you expand that? What is PNH? Paroxysmal nocturnal hemoglobinuria. This disorder, remember guys, it is about paroxysmal nocturnal hemoglobinuria, which is our PNH. Physiology. Remember guys, exclusively in our RBCs to prevent hemolysis. To prevent hemolysis, there are 3 important complement, remember guys, regulatory proteins. This complement regulatory proteins prevent hemolysis from complement proteins attack. What are these 3 group of complement regulatory proteins? Their primary function physiology is to prevent hemolysis. They are, first one we have something called as CD55 present in the RBC membrane, which is also called as DAF, which stands for decay accelerating factor. The second one, put lot of star marks and create a galaxy of stars. This is the most important protein out of this 3, which is CD59. The name itself is self-explanatory. It is called as, remember guys, membrane inhibitor of reactive lysis. Reactive lysis, complement mediated attack of our RBCs, it is going to inhibit. It is present in the membrane. Simple. Membrane inhibitor of reactive lysis, which is our CD59. Out of this 3, the second one, CD59, is very important. And third one is called as C8 binding protein. Physiology. What are these 3 proteins? They prevent hemolysis of RBCs. And most important point, for their synthesis, you need an important gene, which is called as PIGA. Another MCQ. What is this? Phosphatidyl inositol glycan. PA is phosphatidylinositol. Simple. This G stands for glycan. This gene, if it undergoes mutation, you will definitely get paroxysmal nocturnal hemoglobinuria. Very simple concept. 3 proteins in RBC. CD55, CD59, C8 binding protein. What is their primary function? Tell me guys. They prevent hemolysis. For their synthesis, which gene is responsible? PIG-A, phosphatidylinositol glycan A. If it undergoes mutation, the disorder we will have is paroxysmal nocturnal hemoglobinuria, which is characterized by hemolysis. Next important point. This disorder is classically characterized by an important triad, that is hemolysis. Second one, if you note in the clinical scenario, there is pancytopenia. And finally, we have venous thrombosis. Just combine this all, the classical triad of paroxysmal nocturnal hemoglobinuria. This venous thrombosis is the most common cause of death in this group of individual. In the scenario we saw, there is a thrombosis of IVC. So it's a part of a triad: venous thrombosis, pancytopenia, hemolysis. Paroxysmal nocturnal hemoglobinuria triad. This thrombosis is the most common cause of death. Exclusively during sleep, there is slight fall in pH. This activates our complement proteins. That is why exclusively in the night time, there is hemolysis. In this group of individuals, physiology. Normally, in sleep, we all have slight fall in pH. This is the requirement to activate complement proteins. Exclusively, we have something called as membrane attacking complex, which is C5 to C9. More specifically, it is C5b to C9. It is this important membrane attacking complex. It is going to attack the RBC membrane, eventually leading to hemolysis. Very beautiful. A very, very, very beautiful concept. Sleep, fall in pH, activate complement proteins, formation of membrane attacking complex, C5b to C9, hemolysis. This happens only in the PNH, not in normal individuals. When those 3 proteins are deficient, you get PNH. And exclusively, a very, very, very important part now, treatment of paroxysmal nocturnal hemoglobinuria. We have something called as anti-C5 antibody, because it is the membrane attacking complex we are worried about. C5 is a part of that membrane attacking complex. So anti-C5 antibody, we have something called as eculizumab. The most recent one, remember, ravulizumab. This ravulizumab is actually long-acting when compared to eculizumab. Eculizumab, ravulizumab. This ravulizumab is long-acting. It is anti-C5 antibody, which is going to inhibit our membrane attacking complex. We are using anti-C5 antibody, eculizumab, ravulizumab. The definitive cure actually for this disorder is hematopoietic stem cell transplant. Actually, the cost of these drugs are very, very, very high. We are using them, but their cost is very high. If you want to go for a definitive cure, it is always hematopoietic stem cell transplantation. What is the disorder we discussed about? Paroxysmal nocturnal hemoglobinuria. Now you understand the theme of this discussion. What is that, sir? No 4 options will be there. We will discuss whatever possible MCQs from this important clinical case scenarios. Now guys, the next MCQ. Yes buddy, are you ready? A 39-year-old male was admitted for elective hernia repair surgery. Anesthetic induction was performed with midazolam, propofol and ramifentanil. Neuromuscular relaxation was performed with succinylcholine. Remember succinylcholine. At the end of surgery, progressive rise of end-tidal carbon dioxide was observed along with tachycardia and rise in axillary temperature. Initial lab investigations reveal mixed acidosis and hyperkalemia. No doubt at all. I know you all know the answer. What is this clinical condition which is actually medical emergency? Physiology, pharmacology and anesthesia. And this disorder is none other but our, remember guys, malignant hyperthermia, MH. First, physiology. There are two important calcium channels exclusively in our skeletal muscle, very important for muscle contraction. The first one, we have something called as dihydropyridine receptor, which is a type of long-lasting L-type calcium channels. And one more is ryanodine receptor. Remember, these two important calcium channels interact mechanically. Put lot of star marks, INI, CT, MCQ. Their interaction is mechanical. Whenever action potential activates this dihydropyridine receptor, they both will undergo coupling, leading to, underline this R, release of calcium from ryanodine receptor. This calcium is very important for muscle contraction. Basic physiology. There are two calcium channels. The L-type calcium channel is dihydropyridine receptor. We also have ryanodine receptor. Both are mechanically interacting. When action potential activates this dihydropyridine receptor, they undergo coupling, leading to release of calcium, R for R, from ryanodine receptor. Calcium comes, muscle contraction. Most important point. One more important physiology, exclusively when any individual is exposed to a cold environment, what actually happens is shivering. What is this shivering, sir? It is a type of sustained muscle contraction. Cold, we undergo shivering, right? Why body does this? Why hypothalamus activates this mechanism? Because sustained or enhanced muscle contraction always generates body heat. So to combat cold, shivering, sustained muscle contraction, we generate body heat to combat that cold. Now physiology. I know you guys are clear in this physiology. Now physiopathology. This dihydropyridine receptor is actually coded by an important gene, CACNA1. CACNA1. That is its alpha subunit. Mutations here. And ryanodine receptor, RYR1. Any mutation here. These two mutations leads to our clinical state, malignant hyperthermia, which is actually a gain of function mutation. They become overactive, enhanced release of calcium, enhanced muscle contraction, leading to malignant hyperthermia. From normal physiology, remember guys, this dihydropyridine receptor coded by CACNA1, which is actually a gene, CACNA1. A stands for alpha subunit. RYR1. When this two undergoes mutation, there is enhanced release of calcium, sustained contraction, malignant hyperthermia. The patient classically presents with elevated end tidal CO2. Next, most important, they will have mixed acidosis. Most importantly, there is tachycardia. Remember guys, there is hyperkalemia. There is going to be a rhabdomyolysis. Eventually, the most important hallmark is rise in body temperature. These individuals presented with elevated end-tidal CO2, there is mixed acidosis, there is hyperkalemia, there is tachycardia, there is rhabdomyolysis, because lot of important enzymes are sensitive to temperature. They become overactive. Increase in body temperature, which is the classical hallmark of this important disorder. Which disorder? Malignant hyperthermia. Exclusively susceptibility. Any individual who is having susceptibility to develop malignant hyperthermia, how to find out? Again, in relation to physiology, that is why I am discussing. Malignant hyperthermia prone individual, susceptibility. We have something called as, yes, what is the test? CHCT, which is, remember guys, caffeine. H stands for halothane. C stands for contracture. T stands for test. In this group of individuals, we give varying doses of caffeine and halothane. Exclusively, we take muscle samples from vastus group of muscles. And from this muscle biopsy, we will give these two important agents, caffeine, halothane, and look for the muscle tension generated. Very important. Any individuals who is susceptible, they will have a sustained increase in muscle tension. That means because of contraction, there is increase in tension. That is the important point. Muscle tension rises in the susceptible group of individuals when we are using caffeine, halothane. We have this test called as caffeine halothane contracture test, which is actually a very important test to find out the susceptibility of an individual to develop malignant hyperthermia. In vastus group of muscles, actually what are we measuring? The tension generated. In this important sensitive group of individuals, definitely there will be sustained contraction, sustained tension generation. Now, as I told you guys, this is a medical emergency. The most important treatment for malignant hyperthermia we use is dantrolene sodium, which actually blocks our ryanodine receptor. Enhanced calcium release from ryanodine receptor. So block them with the help of dantrolene sodium. The body temperature is rising. Very basic treatment. Administer cooling strategies. There is acidosis to combat that, IV bicarb. And most importantly, remember guys, there is also rise in end-tidal CO2. We do something called as hyperventilation with 100% oxygen. And obviously, we also use fluids for treatment here. The most important treatment, dantrolene, inhibitor of ryanodine receptor. Because there is increase in heat, cooling strategies, there is acidosis, IV bicarb for treatment, hyperventilation with 100% oxygen, and finally we also give fluids. This clinical status, malignant hyperthermia. These are all the possible MCQs you can expect from this malignant hyperthermia. Now the next question guys. Yes buddy, are you ready? A 55-year-old male was admitted for difficulty in walking and difficulty in speech for the past 2 years. He had no familial history of gait disturbances. He was unable to walk without assistance. He was noticed to be having tremors when asked to touch his nose with his fingers. Brain MRI showed cerebellar atrophy, especially in the left hemisphere. A very important brain part, cerebellum and its associated lesions have lot of pathophysiology behind. We'll discuss about it. Definitely the problem lies in cerebellum here. What is the importance of this brain part cerebellum here? Never forget, lifelong. The most important function of cerebellum we call as start, stop signaling. Cerebellum is that brain part which determines when you have to start a movement, when you have to stop that movement. If this starting and stopping is proper, not only in movements, everything in your life, if starting and stopping are proper, then we are well and better coordinated. This most important function, we simply say coordination. What is the basis behind that? Start, stop, signal. What are the requirements to perform this function? Remember cerebellum guys, very simple. 5, 4, 3. What are they? 5 cells. Simple. You have a star-shaped cell here. Star-shaped simply means we call them as stellate, star-shaped. Under microscopy, if you see something looking like a basket, you can simply name them as what cell? Basket cell. Under the microscope, if you see lot of small dots inside, looking like a small, fine, minute granules, we call them as granule cell. Perhaps in the microscopy, if you see the largest cerebellar cell, that is our Purkinje cells. And finally, we have Golgi cells. Stellate, basket, granule, Purkinje, Golgi. What about fossa? We have nuclei. And remember guys, these are very deep in location. That is why we simply call them as deep nuclei. It can denote any one of these four. Simple to remember. It go in that order, alphabetical order. D, E, F, G. What is D? Dentate nuclei. What is E? Emboliform nuclei. What is F? Fastigial nuclei. What is G? Globose nuclei. Simple. Finally, we are moving into 3, which is the most important one eventually. 3 parts corresponding to 3 functions. We have something called as spinocerebellum, which is exclusively important for the most important function, coordination. We have something called as vestibulocerebellum and the corresponding flocculonodular lobe. Flocculonodular lobe. Vestibulocerebellum, very important for equilibrium, maintaining equilibrium and balance. Finally, we have as a part of evolution the newly evolved neocerebellum, which developed this important role in planning of motor movements. Simple. 5, 4, 3. 5 cells, 4 nuclei, 3 important parts and corresponding 3 functions. Where every examiner is going to ask MCQ from apart from this area, whenever there is a lesion of cerebellum, definitely because of its functions will get altered. We are now going to see cerebellar lesions, findings or features. Most important first one, the major function is coordination. Obviously in lesions there will be incoordination. What is the MCQ point? What you will find in the clinical MCQ scenario? You will get something called as truncal ataxia. Ataxia, incoordination of movement, classically seen in cerebellar lesions. Cerebellar lesions. Incoordination, truncal ataxia. Remember guys, second, they always have a wide-based stance. Remember, this is mainly to maintain balance. They have a wide-based stance, balance. Just if the patient comes to you to your OPD, opening the door, you will immediately find there is cerebellar lesion. How? Their head will do something like this. What is this? Any idea? Especially tremors in the head region. We call this as, remember guys, titubation. Fourth, normally how we walk? Heel, toe. Heel, toe. This important cerebellar lesion, they will have difficulty to walk in tandem. They will have difficulty to walk in tandem. The normal walking process, heel, toe, it is not possible in them. They will have difficulty to walk in tandem. What all we have seen? Truncal ataxia, wide-based stance to maintain balance, tremors in the head, which is our titubation, difficulty to walk in tandem, and next, you look at me. I am looking there, looking at you. Looking there, exactly stopping at looking at you. This important normal eyeball movement is not possible in them. Difficulty to start and stop. What will happen in them? Their eyeball will definitely have something called as nystagmus. Very important clinical finding. Now next, look very carefully. there is something called as decomposition of movements. The pen is in front of me. My mind is thinking to take this pen. I am taking. This is a normal movement, but cerebellar lesion. They will first look into the pen. They will take their hand. They will place it. And then slowly they will take. Everything is slow. That means there is decomposition to every single individual movements. It's a complex movement. I am directly taking this. But them see, go, touch, take. So it is broken down into its individual parts. Decomposition of movements, which is also called as dyssynergia. Next, remember guys, we have something called as dysmetria. What is the meaning of dysmetria, sir? Which is also called as, remember, post pointing. So they will not stop exactly at the target. They will go beyond or in front of the target. They will stop either beyond or in front of the target, not exactly at the target. We call this as dysmetria, which is also called as post pointing. Again, a problem in start-stop signaling. Now look very carefully. Put lot of star marks. Remember this important point. Now I am going to tell you like you remember our national anthem, Jana Gana Mana. What is that, sir? There is something called as kinetic tremors, which is also called as, otherwise called as intentional tremors. Kinetic tremors or intentional tremors, which is exclusively seen during the activity, which is not at rest. They are not resting tremors. During a motor movement, whenever you are intended to do an activity, that time only it becomes more pronounced. Kinetic tremors or intentional tremors. Especially if they ask the subject to touch their finger to their nose, they will go near, but whenever they reach their target, they'll have tremor like this. They'll have tremor like this. They'll have tremor like this. Intention tremors. What is this? Kinetic or intentional tremor. The manifestation abnormality in our finger nose test. One more thing. Heel shin test. They are all important tests to find out this important thing. Kinetic tremors or intentional tremors. Very important. Other than that, they will also have dysarthria. They have something called as scanning speech. They will slowly speak the words one by one. The lesions in cerebellum, like this, scanning speech. Dysarthria, scanning speech. Next, most importantly, look carefully guys. Difficulty exclusively during the knee jerk. Start, stop. But in the cerebellar lesion individuals, it oscillates like a pendulum. Knee jerk, that knee joint movement go back and forth. It will not stop. What we have is a pendular knee jerk. Alternating supination and pronation. Alternating supination and pronation. It is possible in me, but in them, it is definitely not possible. They'll do something like this. They'll forget. Then after some time they will do like this. Then go here. They go here. Totally haphazard. This difficulty is called as dysdiadechokinesia, which is actually the difficulty in alternate supination and pronation. What is this important one, sir? Dysdiadechokinesia, which is having a difficulty in alternate supination and pronation. We are discussing lot of important manifestations in cerebellar lesion. They will also have, remember guys, hypotonia. So whole lot of manifestations we have seen. What are all the important things we have seen? Incoordination, truncal ataxia, wide-based stance to maintain balance, tremor of the head, titubation, difficulty to walk in tandem, nystagmus, decomposition of movements, dyssynergia. That means the movement is reduced to their individual movements. Dysmetria, post pointing, which is stopping beyond or before the target, not exactly at the target. We have kinetic tremors, also called intentional tremors. There's dysarthria, scanning speech, pendular knee jerk, dysdiadochokinesia, hypotonia, and finally, there is something called as impaired check. You give a huge resistance to me. Take your hand. There's a check to this movement. I normally have a check to this movement. My cerebellum is normal. Give a resistance. Take away. The movement is checked. There's a check post. It is stopped. But impaired check. In cerebellar lesion, give the resistance. Take away. Impaired check. Impaired check. They will not stop. There is impaired check. What is this phenomenon called as? Rebound phenomenon. All these are very important manifestations as far as cerebellar lesions are concerned. There are a whole lot of clinical findings. All were asked before, but the most important one is kinetic tremors or intention tremors. Pay huge attention to cerebellum. 1 or 2 questions definitely sure shot. Welcome back, guys. Now the next question in front of us. What is this scenario about? Yes. Now, a 64-year-old female was admitted with a 2-week history of right occipital headache that is radiating to the neck. It is associated with the blurring of vision. Neurological examination revealed bilateral papilledema, partial right third nerve palsy, and sensory neural hearing deficits. Lot of neurological findings. Lab investigations reveal positive reaction to antibody against GFAP. So definitely GFAP stands for glial fibrillary acidic protein. Anything that is positive for GFAP, remember, it is astrocytoma. So we are going to discuss about the importance of this glial cell. Perhaps the most important out of all the glial cells is our astrocytes. Astro, remember guys, a star-shaped glial cell. There are 2 important type of astrocytes. We have something called as protoplasmic astrocyte, which you see mainly in the gray matter. Fibers, white matter fibers. We have fibrous astrocytes, white matter fibers. Fibrous astrocyte, which is exclusively found in the white matter. Astrocytes, 2 important types. Protoplasmic in the gray matter, fibrous astrocytes in the white matter. Remember, they have a very important intermediate filament which is actually useful as a tumor marker. What is that, sir? G, glial. Under microscope, they look like fibrillary. Their chemical reaction is acidic. Their structure is a protein. Glial fibrillary acidic protein. In this important discussion, we are exclusively going to focus mainly on the functions of our astrocytes. First, most important in the order of timeline, remember, they play a very important role in development. They provide the road. Road is for transport, road is for migration. And this road, remember, is very important for migration of neurons to their respective locations or destinations. What we call this important thing as radial glial cells, which is actually our astrocytes. Astrocytes provide the pathway, they provide the road. Radial glial cells are none other but our astrocytes. They provide the pathway, road. Something is there in the middle part of our brain. If it have to go to cerebellum, you need the transport pathway further, the GPS system, right? The road, developmental. These radial glial cells provide that pathway, neurons will follow, that's all. Migration of neurons to their respective location. Second, remember guys, astrocytes are capable of proliferation. We have any injury, there is something called as astrocytic scar or a glial scar reaction. They have the capability to undergo proliferation. So any injury to the brain, they undergo proliferation. Under microscopy, we have something called as astrocytic scar or a glial scar. Pathologically very important since they undergo proliferation. Most common glial cell tumor is always of astrocytic origin. Now you understand the significance. Among the glial cells, astrocytes have the capability to proliferate. In normal injuries, they undergo proliferation, astrocytic scar. But pathological proliferation is also possible in them when there is any mutation. Most common glial cell tumor is always of astrocytic origin because they have the capability to undergo proliferation. Third, very important function of our astrocytes. Remember guys, they produce certain important growth factors. One important name is thrombospondin. Underline this S. Astrocytes produce a growth factor that is called thrombospondin. S here stands for, it plays a very important role in synapse formation. Remember guys, astrocytic growth factor, thrombospondin, very helpful as a growth factor to mediate synapse formation between neurons. That growth factor is thrombospondin from astrocytes. Fourth, we have something called as environmental modulation. This environment we are talking is the environment of neurons. This neuronal signaling lead to release of potassium. Following any action potential, there is movement of potassium. This potassium needs to be recycled. If potassium stays there itself following signaling, the next signal, next action potential initiation will not be proper. You need to have potassium recycling. This is mainly done through our astrocytes. Astrocytes are connected together by, very important point, gap junctions. Astrocytes have gap junctions. Astrocytes are connected together by gap junctions. Through these gap junctions, they will take this potassium and throw this potassium into perivascular space. So they are moved away from the neurons. That neuronal environment is clear now. It can initiate its next action potential. Following action potential, potassium leakage, this potassium needs to be recycled. This environmental modulation is done by astrocytes. They have gap junctions. Through these gap junctions, they take potassium and throw them into the perivascular space, thereby clearing the neuronal microenvironment of this potassium. This is potassium recycling. With the help of gap junctions, astrocyte does this. Next, fifth, neurotransmitter release. Most important. For this aspect, consider this as our neuron. Consider this as our astrocyte, which is our glial cell we know. Neuron is releasing this neurotransmitter, glutamate. Once the function of this glutamate is over, remember guys, this astrocyte will take inside this glutamate. It will simply add ammonia. With the help of glutamine synthase, glutamine is going to get synthesized. Glutamine synthase, it converts that into glutamine. Very important aspect. Neuron as a part of signaling releases this neurotransmitter glutamate. Astrocytes take this glutamate inside. It simply add ammonia. With the help of glutamine synthase, glutamate is converted to glutamine. We call this as glutamate-glutamine cycle. Glutamate-glutamine cycle between neuron and astrocyte. The enzyme responsible here is glutamine synthase. Important thing, remember, most important thing, ammonia is added here. This is a way mechanism. Astrocytes helps in detoxification of ammonia in the central nervous system. It is detoxifying this ammonia by adding this to glutamate, and glutamate is converted into glutamine. Ammonia is added. Ammonia is a very toxic substance. CNS should get rid of this ammonia. Astrocytes is actually involved in detoxification of this ammonia. No free ammonia will be accumulated. Detoxification of ammonia. What is the cycle? Glutamine-glutamate cycle between neuron and astrocytes. Next important point. It can also release neurotransmitters like GABA. We all know GABA is an inhibitory neurotransmitter, modulating many neuronal function. So first is this glutamate. Second is the release of GABA. And third, this newer neurotransmitter ATP. Astrocyte is also involved in release of ATP. ATP has got diverse function as a neurotransmitter. The information, lot amount of information is coming up. It's a new information. ATP is now considered to be a neurotransmitter. Astrocytes can release them. So along with glutamate, glutamine cycle, also remember astrocytes can release GABA. It can also release ATP. Next, look very carefully, guys. There is something called as functional hyperemia. That means brain areas, if they are active, that means any region of brain that is active, there is increase in blood flow there. This is the basis for our investigation, functional fMRI. Very simple logic. I'm talking now, writing now. So these writing areas, the speaking areas, I'm looking at you, these vision areas, they all have increase in blood flow now. If you do my fMRI, definitely you will see increase in blood flow in these corresponding areas. An important reason for this functional hyperemia, astrocytes play a role. Extremely important new information for you guys. Again, our neurotransmitter glutamate. This glutamate is going to act on this astrocyte. It is having an important receptor whose name is neuroligin receptor. The receptor for glutamate found in astrocytes is called neuroligin receptor. Glutamate acts here. So from this astrocytes now there is increase in formation of arachidonic acid derivatives. What are the arachidonic acid derivatives? Remember, prostaglandins. They are vasodilators. They increase blood flow. So any region that is active, you need more blood flow there. Astrocytes play a role. Glutamate, with the help of neuroligin receptors in astrocytes, they increase the production of arachidonic acid derivatives, which are none other but our prostaglandins. They are vasodilators. They increase blood flow. So there is an important concept we call this phenomenon as neurovascular coupling. Who is having a role here? Our astrocytes are having a role here. Functional hyperemia, neurovascular coupling, these words don't remain difficult for you hereafter. The concept is very clear. There is a coupling between a neuronal structure and a vascular leading to increase in blood flow. Astrocytes play a role. With the help of prostaglandins, they increase blood flow. Functional hyperemia. It is the basis for our functional fMRI. And finally, guys, last but not least, our astrocytes help in formation of a very important barrier, which is our blood-brain barrier, which is a simple barrier to restrict substance movement. Not all substances can cross from blood into the brain. You need some certain specific requirements, but many substances are also toxic. You cannot send them into brain. There is a barrier. This barrier is our blood-brain barrier. Astrocytes play a role. A very important point. Consider this as our brain tissue. This as our brain tissue. A blood vessel is actually in between. This blood vessel have got endothelium. Remember, this endothelium here have tight junctions. So substance cannot cross easily. So the first reason for a blood-brain barrier is the tight junctions found in the vascular endothelium. The second important reason is our hero under discussion here, which is this star-shaped glial cell we know is the astrocyte. This astrocyte has got a foot process which end as something called as a, remember, end feet. This foot processes end like a feet, we call that as end feet, which further reinforces this tight junctions in the endothelium. So endothelium having tight junctions, which is further reinforced by our astrocytes. It foot processes, the ending of them are called as end feet. A strong hold. Endothelium is further having a strong support here. This end feet also plays a role in blood-brain barrier. So the blood-brain barrier is found between the endothelium of the blood vessel and the astrocyte foot processes. We call that as the end feet. So not all substances can pass. This barrier is called as blood-brain barrier. I have told you a lot of information about astrocytes, a few information new also. So astrocytes, glial cells, glial fibrillary acidic protein, one of the common repeat MCQ guys. Right guys, the next MCQ. A 70-year-old male was admitted for his inability to move left arm and left leg past 2 days. He is a known hypertensive under treatment. Lab investigations revealed hemoglobin level of 7, serum creatinine value of around 7, and his estimated GFR is 10 ml per minute. He is under treatment taking erythropoietin. What is this guys? He is definitely having anemia. GFR is very low, hypertensive because of chronic kidney diseases. He is under having treatment with erythropoietin. So the primary focus of our discussion for this question is our erythropoietin. We simply call that as EPO. Remember, this erythropoietin is a glycoprotein guys. Its primary action is to increase RBC. For this action, it needs a receptor, which is our Janus kinase receptor. JAK STAT pathway receptor. Exclusively the isoform is JAK2. Erythropoietin, acting through this receptor, inhibits the apoptosis of RBC and the developmental cells leading to the formation of RBC. It is inhibiting the apoptosis of all the cells concerned with RBC development. It prevents the apoptosis, thereby increase in RBC number. Most important concept. The primary source, 85% of erythropoietin comes from kidneys. Exclusively from the cells called peritubular capillary cells. Major source, 85% of circulating erythropoietin comes from the kidney. The cells, it was asked before, peritubular capillary cells. Remaining 15% of erythropoietin, the source is liver. Which cells from liver, sir? Remember, perivenous hepatocytes. In kidney, peritubular capillary cells. In the liver, the remaining 15% perivenous hepatocytes. Also remember, erythropoietin is also found in brain. It is also shown to be present in uterus. It is also shown to be found in fallopian tubes. So the major source is kidney. Next is liver. It is also found in brain, uterus and fallopian tubes. Now, the most important point. The primary stimuli for erythropoietin releases. Any guess? Definitely it is going to be hypoxia. Anything that lead to hypoxia, that is the important thing I am telling you for our next discussion, upcoming discussions. Anything that can cause hypoxia can release erythropoietin. This mechanism, molecular mechanism, is very, very, very important. It was actually awarded Nobel Prize, so you need to be thorough on this mechanism. We have something called as hypoxia inducible factor, which is considered to be the transcription factor for erythropoietin. Whenever there is normal oxygen tension, this hypoxia inducible factor combines with something called as some von Hippel-Lindau protein. They form a complex. This complex undergoes destruction. Simple logic. Body always do simple things, guys. It never complicate anything. Hypoxia inducible factor is only needed during hypoxia. When there is normoxia, you don't need them. This hypoxia inducible factor combines with von Hippel-Lindau protein. This complex undergo destruction. Now, it is not always normal, right? Sometimes we undergo hypoxia. During hypoxia, this hypoxia inducible factor is separated because you need them now. This hypoxia inducible factor, it's a transcription factor, increases production of erythropoietin that acts in the RBC lineages, leading to increase in RBC. A basic mechanism, hypoxia inducible factor, this transcription factor. Also remember this von Hippel-Lindau protein. Now, with this idea, you know the stimulus for erythropoietin is hypoxia. When you will see increase in erythropoietin secretion, remember, someone who is climbing in the high altitude, there is definitely hypoxia in high altitude leading to increase in erythropoietin. First, second, very, very, very important. In smokers, there is increase in erythropoietin. We call this as smokers polycythemia. Then third, this von Hippel-Lindau protein mutation leading to increase in erythropoietin, we have something called as PCOS polycythemia. In smokers polycythemia, von Hippel-Lindau protein mutation, we have something called as PCOS polycythemia. Next, fourth, remember guys, renal artery stenosis. Very, very important. This renal artery stenosis can lead to hypoxia. Definitely there is increase in erythropoietin. High altitude. In smokers, increase in erythropoietin. In von Hippel-Lindau protein mutation. In renal artery stenosis. Remember, there are certain tumors where there is ectopic EPO, erythropoietin production, leading to increase in RBC and polycythemia. Most important first one, renal cell carcinomas from the kidney, remember? Hypernephroma. Second source is liver, obviously, hepatoma. Third, exclusively from the cerebellar, hemangioblastoma, ectopic erythropoietin production. And finally, some pancreatic neuroendocrine tumors. All this is characterized by polycythemia, increase in RBC, tumor cells producing erythropoietin from the kidney, hypernephroma, liver, hepatoma, cerebellar hemangioblastoma, and pancreatic neuroendocrine tumors. Remember guys, it is the Janus kinase receptor, I told you, JAK2. If it is overactive, there is clonal proliferation of RBCs. We call this state as polycythemia vera. Overactive, gain of function mutation of Janus kinase 2, erythropoietin becomes overactive here. That is why you need to block this Janus kinase 2 receptor for treatment. What is this drug called? Ruxolitinib. For treatment of polycythemia vera. What I told you, JAK2 is needed for erythropoietin action. If it is overactive, there is clonal proliferation of RBCs, polycythemia vera. For treatment, you need to inhibit this kinase. It's a kinase inhibitor, Janus kinase inhibitor, JAK2 inhibitor, ruxolitinib for polycythemia vera. And finally, we presently have recombinant erythropoietin available for treatment. First one is called as epoietin alpha. We also have something called as darbepoietin alpha. Epoietin alpha, darbepoietin alpha, it is exclusively useful in treatment of, remember guys, anemias of chronic kidney diseases. And also you will definitely see this in every single patient whoever is undergoing dialysis. So chronic kidney diseases, less erythropoietin production, you need to give it from outside. Epoietin alpha, darbepoietin alpha for treatment of anemia of chronic kidney diseases and also in dialysis. Erythropoietin is very important. All the points I told you was asked before. There were few future predicted MCQs also from this discussion. Erythropoietin is very important. Welcome back guys. Now the next question in front of us. A 7-year-old boy was admitted with 1 week history of high-grade fever, increased productive cough. He was noted to have dextrocardia and persistent neonatal respiratory distress. On examination, he had bilateral wheeze and crepitations at lung bases. Investigations revealed static cilia throughout the sample examined. So this discussion is definitely going to be about this important structure cilia. In recent examinations, this topic is addressed. Cilia. What is the significance? What is the pathophysiology? Let's find out. We all know the most important first point, the lung, especially in the airway epithelial cells, they are ciliate. Consider this important airway epithelial cell. It has got a finger-like projection which is called as cilia. This cilia is capable of movement. Thereby it is going to provide us an important function. This ciliary movement gives rise to an important concept which is called as mucociliary escalator. This function is called mucociliary escalator. This cilia is capable of moving. This is our cilia. Above the cilia, what we have is something called as periciliary fluid. There is a periciliary fluid. On top of that, you have an important secretion. What is this secretion, sir? Mucus secretion. This mucus secretion we all obviously know is sticky. So any important foreign particles coming from the external environment, they come because of the sticky nature of the mucus, they get stick to it and immediately halted its progression there itself. Mucus halts their progression. They are sticky. They just capture this any foreign particle, aerosol particles for that matter. Now this cilia will move all these particles towards nasopharynx so that you can expel them out in the form of sputum. This ciliary movement is considered to be giving us a protective function, so that foreign aerosol particles, anything for that matter, cannot go deep into our respiratory tract. This alveoli and all we have to protect. So for that, an important protective mechanism above, we have this mucociliary escalator, which is a protective function. All the cilia bend towards nasopharynx so that you can expel those foreign particles in the form of sputum outside. This coordinated movement of cilia all bend towards nasopharynx. We call this phenomenon as metachromism. All these are important MCQs. All the cilia beat towards nasopharynx. We call that as metachromism. We need to understand first and foremost cilia beat frequency. How much is this, sir? Usually 10 to 15 Hertz. Because later I will tell you the ciliary beat frequency has got an important diagnostic role. Ciliary beat frequency, normally it is 10 to 15 Hertz. They are moving those particles towards nasopharynx. This movement rate is usually 16 millimeter per minute. Because of their bending, because of their movement, they move those foreign aerosol particles outside to the nasopharynx. This movement, this rate of movement is usually 16 millimeter per minute. Remember their beat frequency Hertz, 10 to 15 Hertz. The rate of movement, these particles move because of cilia at the rate of 16 millimeter per minute. So we are discussing about cilia. This cilia, starting from the anterior third of nose till the beginning or start of respiratory bronchioles, you see cilia. Remember the cilia, starting from the anterior third of nose till the start of respiratory bronchioles, you definitely see this important structure, cilia. The cilia is protective. It is going to give us an important function, mucociliary escalator. Remember this beat frequencies, remember this movement rate. All were asked as MCQs before. Now, extremely important concept, this ciliary ultrastructure. Very, very important. Again for diagnosis, later I will tell you. This ciliary ultrastructure, this ciliary is capable of movement. The cilia movement is mainly because of something called as microtubules. The cytoskeletal filaments responsible for cilia movement is microtubules. Among this, especially it is the dynein, which is very, very important. Cilia, the primary component here is a microtubule. Among the microtubule, it is the dynein that is very important for ciliary movement. The ciliary ultrastructure, how it will look like? Look guys, the cut section. What we have first is the cell membrane or the plasma membrane. This classical 9+2 arrangement of microtubules, you see here, look very carefully. 1, 2, 3, 4, 5, 6, 7, 8, 9. They are all connected together by an important structure. What is that structure, sir? They are connected together by a structure which is called nexin. They also have a projection which is called as radial spikes. What I told you? They are connected together by nexin, the outer 9. They also have something called as a projection, radial spikes. In the center, you see 2. This is the classical 9+2 microtubular arrangement you see in cilia. The outer ones are connected by nexin. They have a projection which is called radial spikes. Perhaps the most important, the one present outside, the one that is present inside. We have dynein. I told you this is the outer dynein arm. This is the inner dynein arm. Absence of this dynein, remember, if dynein is absent, this cilia will not move. This cilia becomes immotile. So correspondingly, we have something called as immotile cilia syndrome, which is also called as, remember guys, primary ciliary dyskinesia. The simple basic concept is cilia is not moving. Movement is kinetics. Not moving is dyskinesia. What is not moving? Cilia. These are primary disorders affecting our lung cilia. Primary ciliary dyskinesias. One important syndrome here is our very well known Carter-Jenner syndrome. These are not difficult at all. Cilia is moving because of microtubules, especially dynein. We have the classical 9+2 arrangement. The outer ones are connected by nexin. They also have radial spikes. Inside you will see 2. And in this cilia, you always see outer dynein arm and inner dynein arm. Absence of dynein, the cilia will not move. immotile cilia syndrome or primary ciliary dyskinesias. The most important one is Cartagena syndrome. Now, very important. Cilia, its disorders. To find out, you need certain investigations. Pay huge attention. From here, definitely we are expecting lot of MCQs in near future. Already they asked this question. So this topic is very important. First and foremost is screening. Whether the cilia is moving properly or not. For screening, underline this. Yes, we have something called as saccharin test. We place the substance saccharin in the inferior turbinate of nose. We measure the time taken to taste this substance in the mouth. As I told you, anterior third of nose, from there you will have cilia. If you place the saccharin exclusively at the inferior turbinate, we measure the time taken to taste it. It is an important screening test to assess ciliary motility. Other than that, diagnostic ones. What are the diagnostic ones, sir? You need to assess ciliary beat frequency. I told you it is 10 to 15 Hertz. You also need to assess ciliary beat pattern with the help of something called as high speed videography. This technique is very important. For diagnostic purposes, we have ciliary beat frequency analysis, ciliary beat pattern analysis using high speed videography. Perhaps the most important one. There may be lot of important tests, but only one is always considered to be definitive diagnostic test. Any idea? What is the definitive diagnostic test to find out the problems in cilia? It is to assess, remember guys, ciliary ultrastructure. You have to show there is absence of dynein. For that you need electron microscopy. This is the most definitive diagnostic test to find out ciliary motility. We use electron microscopy to find out ciliary ultrastructure, and in that ultrastructure you will have to show there is absence of dynein. Very important. Electron microscopy is the definitive diagnostic test. For screening, saccharin test. Diagnostic purposes, ciliary beat frequency analysis, ciliary beat pattern analysis. What is the pattern? Normally they move towards nasopharynx, which is called as metachromism. The most definitive diagnostic test is estimating ciliary ultrastructure using electron microscopy. Revise this topic, cilia, very high yield. Alright guys, now the next question in front of us is about a 14-year-old girl was admitted for the evaluation of hyperpigmentation of both axillae, back and upper limbs. Hyperpigmentation exclusively characteristic site axilla, back and upper limbs. She is also noted to have excessive hair growth in the face. Lab investigations revealed elevated fasting glucose levels and insulin levels. Both glucose and insulin levels are elevated. Luteinizing hormone is 9.7. Follicular stimulating hormone is 4.6. Ultrasound abdomen shows enlarged ovaries with increased number of peripherally arranged follicles. Any guess? What is this clinical state we are talking about? Yes, I am hearing it from you. Everyone, every single one is telling about polycystic ovarian syndrome. But more specifically in polycystic ovarian syndrome, this condition is, remember guys, hair and syndrome. What does HA stands for? Remember guys, HA stands for elevated androgens, hyperandrogenism. The classical finding you see here is excessive hair growth in a girl, hyperandrogenism. IR stands for insulin resistance. Because of this insulin resistance, the marker for this insulin resistance is something called as acanthosis nigricans. So very important. hyperandrogenism, insulin resistance, acanthosis nigricans. We are classically seeing all these three. Hyperpigmentation of axilla, acanthosis nigricans, elevated insulin levels, hyperinsulinism, insulin resistance, and we also have elevated androgens. She is having excessive hair growth, which is actually a form of our polycystic ovarian syndrome. Remember guys, this polycystic ovarian syndrome, which is also called as Steen-Leventhal syndrome, is characterized by a classical triad. The first and foremost finding here is hyperandrogenism, elevated levels of androgen. Because of that, you will classically definitely see anovulation and polycystic ovaries. This classical triad, three important components of polycystic ovarian syndrome, also called as Steen-Leventhal syndrome. Now we are going to understand this disease process's pathophysiology. The most important first postulated reason for this polycystic ovarian syndrome, remember guys, increase in pulse frequency of gonadotropin releasing hormone. You know this gonadotropin releasing hormone coming from hypothalamus. Here there is increase in pulse frequency in this group of individuals, PCOS. This directly translated as elevated levels of luteinizing hormone from the anterior pituitary. Increase in pulse frequency of GnRH leading to elevated levels of luteinizing hormone. Remember, in this classical state, follicular inhibin, an important substance, inhibits follicular stimulating hormone. The direct effect of increase in pulse frequency of GnRH elevated luteinizing hormone. In the same group of individuals, this follicular inhibin levels are elevated, leading to inhibition of follicle stimulating hormone. So classically we see luteinizing hormone increase, follicular stimulating hormone decrease. We say eventually because of this LH-FSH ratio will be increased. There is rise in luteinizing hormone. Inhibin is inhibiting follicular stimulating hormone. In this PCOS, classically, LH-FSH ratio is increased. Extremely important point. The classical word they say is tonically elevated luteinizing hormone without surge. Without luteinizing hormone surge phenomenon. Tonically elevated luteinizing hormone without surge. You know, for ovulation LH surge is needed. But here it is without surge. This can lead to anovulation. An important part of the triad, relate that. Now, all boils down to this important question. The starting point, why there is increased pulse frequency of GnRH? The postulated reason, leptin is the guy, which is a very important reason for this elevated pulse frequency of GnRH. Not only that, insulin resistance. Also remember, hyperandrogenism. All these three are postulated causes. Leptin, insulin resistance, hyperandrogenism can lead to increase in pulse frequency of GnRH. And further down all the mechanisms we discussed, there is tonically elevated luteinizing hormone level. Without surge, there is anovulation. For our next discussion, we are going to take forward this important point. Tonically elevated luteinizing hormone. Second, look carefully. If you go in this order, you will never ever forget. Luteinizing hormone elevated without surge. Then what it is going to do? It must perform something. Why am I here luteinizing hormone? I have to perform something. Okay. Let me go and stimulate theca cells, which is my normal function. Stimulating theca cells leading to increase in androgen production. Now we clearly know high level of luteinizing hormone. Stimulating theca cells, hyperandrogenism. Now, extremely important point. This increase in androgen is mainly from ovary in female. Here, adrenals. Both ovary and adrenals, there is high level of androgen production. Other than this elevated LH, remember guys, stress by itself can increase androgen production. We have high levels of insulin. This high insulin can stimulate androgen production. Because of high levels of insulin, you also tend to get insulin-like growth factor 1. Elevated levels of IGF-1 can also stimulate increase in androgen production. Most importantly, remember, in this group of females, particularly there is elevated prolactin levels. This elevated prolactin levels can also lead to increase in androgen. What I told you, first primary cause is LH, stimulating thick cells, hyperandrogenism. This hyperandrogenism is also because of stress, insulin, insulin-like growth factors, prolactin. Remember guys, because of all of this, the most important point, the follicular microenvironment is androgenic. Again, coming to the most important point in the triad, this leads to anovulation. Now we can relate everything. This follicular microenvironment now is androgenic because of high levels of androgen. This androgenic environment does not support ovulation. There is anovulation. We are left with one last important thing in pathophysiology of PCOS. Obviously, you all know it is obesity. Obesity by itself can directly lead to insulin resistance, and also most important point, extremely vital concept, in obese individuals it is shown to be there is reduced levels of steroid hormone binding globulin. It is going to bind our steroid hormones, for example estrogen, estradiol. Because of reduced binding globulin, the free estradiol level rises. This is classically seen only in the long standing cases of PCOS, not in all. Mainly in the long standing cases of PCOS, there is reduced steroid hormone binding globulin. This indirectly leads to elevated levels of free estradiol. We all know E for E. This can cause endometrial proliferation. Very important long-term consequence of PCOS. There can be endometrial proliferation. So what we have seen, the first and foremost thing is increase in pulse frequency of GnRH leading to luteinizing hormone. Now follow the discussion. What this luteinizing hormone is going to do? Increase androgen production. There are other causes of hyperandrogenism like what I told you, stress, prolactin, insulin, insulin-like growth factors. Finally, it is obesity. Obesity can lead to insulin resistance and also decrease in steroid hormone binding globulin. In long-standing cases, this can rise free estradiol levels, eventually can cause endometrial proliferation. Polycystic ovarian syndrome, one important form of it, Haran syndrome, is what we have discussed so far. Right guys, the next question in front of us, a 52-year-old female was admitted for the evaluation of pruritic and ulcerating skin rash. There is a skin lesion. This slowly progressed to the entire body within 1 month. She also complained of weight loss. Lab investigations revealed elevated blood glucose levels. Her fasting glucagon levels were significantly elevated. Abdominal CT scanning revealed pancreatic body mass with low density. So definitely we are having 3 classical findings here. The first one is a skin lesion. The second one is weight loss. The third one is elevated blood glucose levels and glucagon levels. Obviously, it is about glucagonoma. A very important component is there. Before going into the pathological aspects, let's first see few important physiology. This is about our glucagon. that mainly comes from, we all know, alpha cells of endocrine pancreas. The precursor for this is pre-pro-glucagon, which is actually processed differently in the alpha cells and L cells found in GIT. In the alpha cells, you are going to get our glucagon. From the L cells, what you get in the GIT, classical substances. Remember, glucagon-like peptides 1 and 2. So they are processed differently, this pre-pro-glucagon. In the alpha cells of pancreas, you get glucagon. From the L cells of the gastrointestinal tract, you will get glucagon-like peptide 1 and 2. The most important aspect, for all the actions of this glucagon, it needs a second messenger. And that second messenger is cyclic AMP. We all know, everyone knows, examiner focuses hugely on second messenger systems. Exclusively for glucagon, its action required the second messenger, cyclic AMP. It was actually asked before. I have given you a very important introductory part for actions, because now we are going to discuss about the actions of glucagon. Clearly, it is hyperglycemic. It elevates blood glucose. Glucagon. How? Most important, first one, it promotes glycogenolysis. Not only that, producing glucose from non-carbohydrate sources. What do you call this biochemical pathway? Neoglucogenesis. It elevates the blood glucose by two important mechanisms, glycogenolysis, neoglucogenesis. First, elevating blood glucose. Second, it is also known to be lipolytic. Third, it is ketogenic. Remember, for all these actions, it uses the second messenger system, cyclic AMP. Increase in blood glucose, lipolytic, ketogenic, very well known functions. Perhaps there are some other functions which are least known. You also need to remember them. It is known to increase myocardial contractility. We call this as positive inotropic effect. Glucagon is known to increase myocardial contractility. It is positively inotropic. For this reason, it is useful in the treatment of physiology and pharmacology. Yes, you told correctly. Say it loudly. You told correctly. Glucagon, positively inotropic. It is used in the treatment of beta blocker overdose. Glucagon increases myocardial contractility, positively inotropic. Physiology and radiology. Any guess? One other least known function. Our glucagon is known to relax intestine. This is useful for, remember guys, X-ray visualization of bowel. Two least known function. It is positively inotropic, enhances myocardial contractility. Useful in treatment of beta blocker overdose. It also relaxes intestinal muscles, remember, for useful in X-ray visualization of bowel. Now, there are certain important factors which are known to increase glucagon. The most important first one obviously is decrease in blood glucose level. Obviously, hypoglycemia. When there is hypoglycemia, you definitely need glucagon because glucagon raises blood glucose. Anything that leads to hypoglycemia like exercise, starvation, there is no glucose. In exercise, glucose is utilized. Starvation, no food intake, low blood glucose. You need to increase your blood glucose now. You definitely need glucagon. Remember guys, fourth one, sympathetic stimulation, especially the beta receptor. Sympathetic beta stimulation can increase glucagon level. Never ever forget, perhaps this is what they asked many times before. protein-rich meal can increase glucagon levels. On the other hand, what are the factors which are known to decrease glucagon? Its antagonist. Most importantly, remember insulin. One universal known inhibitor, somatostatin. Also remember, already there is high glucose levels. You don't need glucagon. When you need to decrease glucagon, when there is insulin, when there is somatostatin, when there is high levels of glucose, this glucagon secretion is inhibited. Now, what we classically see in this patient? A triad. What is that triad, sir? There was weight loss, elevated glucose levels. These individuals are more prone for diabetes mellitus, and a classical skin lesion, pruritic lesion, we call that as necrolytic migratory erythema, NME. There is a triad, 3 important components: weight loss, diabetes mellitus, necrolytic migratory erythema. We call this as glucagonoma syndrome. Very important. This case is actually about glucagonoma syndrome, where you have weight loss, diabetes mellitus, and necrolytic migratory erythema, glucagonoma syndrome. You don't need to confuse this with one other important clinical state where there is alpha cell hyperplasia. This can definitely lead to increase in glucagon. We call this disorder as, remember guys, Mahwah's disease. Mahwah disease. This is not to be confused with glucagonoma syndrome. That is different. What is Mahwah disease? Alpha cell hyperplasia leading to increase in glucagon level. We call that as Mahwah disease. But this clinical state, what we discussed, is glucagonoma syndrome, weight loss, diabetes mellitus, necrolytic migratory erythema. All these important points very high yield for our hormone glucagon. Yes guys, what is the next question in front of us? 57-year-old male was admitted for the evaluation of fever and reddish discoloration of the right foot since 10 days. He is a known diabetic under treatment for the past 5 years. Lab investigation shows fasting plasma glucose 142, postprandial glucose 258, HbA1c 8.1. Urine analysis revealed presence of glucose in the urine. Along with his routine medications, now treatment with an SGLT2 inhibitor drug is initiated. So what is this question about, sir? What are we about to discuss here, sir? Glucose in urine. When glucose will appear in urine? If at all it appears, what you need to think of? So this evaluation is very critical. You need to understand the first and the foremost, remember guys, renal glucose reabsorption. Remember, this important part of nephron, PCT, effectively 100% glucose complete reabsorption happens. If the glucose escapes PCT reabsorption, that's all. No other segment in the nephron is capable of glucose reabsorption. Only PCT is having the capability, proximal tubule is having the capability, the 200% capability, complete effective glucose reabsorption. For that, in PCT, you have a secondary active transport protein, secondary active transport process, and that is called as SGLT, which is our sodium glucose linked transport protein. This isoform is 2. You also have SGLT1. Where this is found? SGLT1? Yes, you are correct. Tell me. True. Say it loudly. You are correct. GIT. SGLT1 in GIT for glucose reabsorption. SGLT2 in proximal convoluted tubule mainly for glucose reabsorption in PCT. This SGLT2 being a secondary active transport, all active transport process shows something called as saturation. What is the meaning of saturation? This process will not continue indefinitely. At one point of time, it will reach a something called as plateau. That means there is a maximum the PCT can transport glucose. We call this as transport maximum of glucose. T, transport maximum, M, G for glucose. That's all. We are going to understand a very important curve. Lot of MCQs were asked before on this topic. Let's understand that first now. This SGLT2 and its saturation kinetics. Consider this important graph, guys, very high yield. X-axis is always about the plasma glucose concentration. This y-axis is the rate of glucose transport. X-axis plasma glucose, y-axis the rate of glucose transport. Listen very carefully. We have to pay attention to two critical parameters. The first parameter in the x-axis, the second parameter in the y-axis. What are all they? You need to understand, we are presenting our nephron with a filtered load of glucose because definitely it is going to get filtered in our nephrons. So that important first aspect is called as, what is this line? Filtered load. Very simple to understand, of glucose. Definitely glucose is filtered. From this filtered load, look very carefully. Lot of glucose will be reabsorbed, not continuously. At one point of time, it will reach plateau. What is this line? Reabsorption line. Above we have filtered load. Next we have reabsorption, where it can happen up to a point of time. Because it shows saturation, it reaches a plateau. Most importantly, this point of attaining this plateau correlate in x-axis, correlate in y-axis. That's all, very simple. When it is reaching plateau, correlate this in x-axis and y-axis. If you look into this x-axis, the value comes around 200. It is plasma glucose, so the unit is milligram per deciliter. What is this parameter called as? This is our renal threshold for glucose, or TG. If it is crossed, if this threshold value is crossed, all the remaining glucose will be excreted in urine. Remember, this is the excretion graph. It comes after 200 milligram per deciliter. Before 200 milligram per deciliter, all the glucose will be reabsorbed. If the cutoff is crossed, remaining glucose filtered will be only excreted. It will not be reabsorbed. I think I made it very simple. After 200 milligram per deciliter, all the glucose will be excreted. This is renal threshold, which is also called as renal glycosuria. This is what is happening in our patient. The case scenario, there is glucose in urine because it crossed the threshold. If it becomes more than 200 milligram per deciliter, you will get renal glycosuria. On the other hand, look into this y-axis, it is the rate of glucose transport. At one point, there is maximum glucose transport. This is its transport maximum. We call this as TMG. And this value usually comes around 375 milligram per minute. The unit is different here. For renal threshold, it is 200 milligram per deciliter because it is the plasma concentration. Rate of transport means per minute. Kidney can maximally transport 375 milligram of glucose per minute. This is our transport maximum. So if they ask you renal threshold, look into the x-axis. If they ask you transport maximum, look into the y-axis. Remember these two important values. We have filtered load graph, we have reabsorption graph, we have excretion graph. Now, there is a small deviation we are clearly seeing. Now look carefully, guys. There is a small deviation between the filtered load and the reabsorption. This is the reabsorption. There is a small deviation. What is this small deviation called as, sir? This is called as splay. From the filtered load, this reabsorption graph is not exactly matching point to point. There is a small deviation between the filtered load and the reabsorption line. We call this phenomenon as splay. What is the reason for this splay, sir? Very important. We call this phenomenon as nephron heterogeneity. Not all nephrons have the same transport maximum. This transport maximum for glucose differs among nephrons. There are a lot of nephrons, millions of nephrons. They all don't have 375 milligram per minute. You definitely don't expect them to have 375. There is nephron heterogeneity. Their transport maximum is different. That is why filtered load and reabsorption are not matching. There is a deviation in the reabsorption curve. And what we call the deviation as a splay. The reason for this splay, nephron heterogeneity, the transport maximum for glucose is different in different nephrons. There is a deviation which is called as a splay. Remember the filtered load graph? Remember the reabsorption where you see splay and also excretion. When you see excretion, if the plasma threshold is crossed more than 200 milligram per deciliter, glucose will be excreted in urine. Eventually, we need to understand it is this channel protein SGLT2. Presently, we have blockers exclusively useful in treatment of diabetes mellitus. Diabetes mellitus is always characterized by elevated glucose level. Now we have the protein responsible for reabsorption. If you block this, glucose will not be reabsorbed. And this group of agents are our glyphosin group of drugs. What are they? Remember? Canagliflozin, dapagliflozin, empagliflozin, sotagliflozin. All these are glyphosin group of drugs. They are SGLT2 blocker, canagliflozin, dapagliflozin, empagliflozin, sotagliflozin. So we have a drug that can block this SGLT2. This is the primary transport protein for glucose reabsorption in PCT. We are blocking this SGLT2 for management of diabetes mellitus. He was started with this new drug, the patient in our clinical scenario, SGLT2 blocker. It can be any one of this, canagliflozin or DAPA, EMPA or SOTA. They are all SGLT2 blockers. Renal glucose reabsorption, very important area. Right guys, what is the next question? A 64-year-old female was admitted for the evaluation of watery diarrhea past 2 weeks. She had a significant weight loss. On physical examination, her abdomen was mildly distended with mild tenderness. Her serum gastrin level was significantly elevated, 870 picogram per ml. Esophagogastroduodenoscopy showed prominent gastric folds and multiple duodenal ulcers. Treatment with a high-dose omeprazole initiated. Now the discussion is open-ended. What all comes in your mind? Sir, only one thing comes in my mind, sir. What is that? A tumor is producing elevated levels of gastrin. What is this syndrome, sir? This syndrome is Zollinger-Ellison syndrome. Simple. Now look very carefully, guys. This discussion is definitely about this prime hormone gastrin. Underline this G, mainly coming from the G cells, exclusively from the antrum region. This important gastrin has got two vital functions. We all know it increases gastric acid secretion physiologically, and also it is this area huge focus on research these days. Gastrin is having something called as trophic action. That means proliferation of mucosa. Not only in the stomach region, throughout the entire GI tract. Remember this important action. It will help you in a lot of ways. Gastrin increases acid production. Trophic action, that means proliferation, growth simply. growth of mucosa throughout the GI tract. Now, very, very important scenario here. What is this scenario about, sir? This is about the Zollinger-Ellison syndrome, ZES. There is elevated level of gastrin here, gastrin hypersecretion, most importantly because of a tumor, a non-beta cell tumor. A non-beta cell tumor producing excess levels of gastrin leading to Zollinger-Ellison syndrome. We all know because of pathologically elevated level of gastrin, we saw in the scenario what happened in that individual. Not normal secretion. There is hypersecretion of gastric acid. This hypersecretion of gastric acid predominantly leading to peptic ulcer, which is actually the most common presenting manifestation. The tenderness is there in her. Peptic ulcer, most common manifestation. High levels of gastrin, increase in acid, hypersecretion. Next, I told you, it has got trophic action, stimulates the growth. There is increase in antral cell mass. Increase in number of G cells. Remember, very, very, very important. This can also lead to increased amount of gastrin, eventually lead to increase in acid secretion. So there is a feedback loop operating here. High levels of gastrin, increase in acid, hypersecretion. The antral cells are having growth because of this gastrin action. The antral cell mass will definitely increase. Gastric acid hypersecretion, antral cell mass increase. Very, very classical findings in Zollinger-Ellison syndrome. Remember guys, in this Zollinger-Ellison syndrome, we do something called as first and foremost secretin test. I'll tell you simply. In secretin test, positivity in Zollinger-Ellison syndrome means there is paradoxical increase in gastrin. That's all simple. No need to complicate anything. Paradoxical increase in gastrin. What is paradoxical? In normal, healthy individuals, remember guys, this secretin is known to inhibit gastrin. In all healthy individuals, if you administer secretin, secretin will inhibit gastrin. Particularly in Zollinger-Ellison syndrome, tumor cells, the action is opposite. That is why we say paradoxical. Secretin is going to stimulate or increase gastrin levels. Secretin test positivity in Zollinger-Ellison syndrome, there is paradoxical rise in gastrin, not seen in healthy individuals, only seen in Zollinger-Ellison syndrome. Next, we have a very important parameter that is called as basal acid output, BAO. Also remember one more important concept, maximal acid output, that is MAO. BAO, basal acid output, maximum acid output, MAO. This basal acid output means in an unstimulated stomach. So you do this normally in the early morning. In the unstimulated stomach, what you get is the acid measurement, basal acid output. Maximal means after stimulation. Using a very important substance which is called as pentagastrin, that is pentagastrin stimulation test. In unstimulated stomach, the acid measurement is basal acid output. Giving pentagastrin a stimulating agent, you get maximal acid output. In Zollinger-Ellison syndrome, the most pathognomonic finding here is elevated levels of basal acid output. Very simple. Elevated levels of basal acid output and also elevated levels of basal acid output by maximal acid output ratio. If it becomes more than 0.6, this ratio, basal acid by maximal acid output ratio, If it becomes more than 0.6, it is diagnostic of Zollinger-Ellison syndrome. So for diagnosis, secretin test is positive in Zollinger-Ellison. There is paradoxical rise in gastrin. Unstimulated stomach, basal acid output elevated in Zollinger-Ellison. Stimulated pentagastrin, maximal acid output. The ratio basal acid output by maximal acid output ratio, if it becomes more than 0.6, it is diagnostic of Zollinger-Ellison syndrome. Remember, most important point, Zollinger-Ellison syndrome 2R. These ulcers are refractory to our treatment, and second are they recur after our treatment. So whatever you do in Zollinger-Ellison syndrome, these ulcers are usually refractory to our treatment, and also they will recur even after treatment. But still, we do one important treatment for Zollinger-Ellison syndrome. The drug of choice are actually considered to be the proton pump inhibitors. Remember, 2Rs, refractory to treatment, they recur after treatment. The treatment we usually do in this patient also, it was initiated, right? Proton pump inhibitor. The treatment drug of choice we usually use is proton pump inhibitors in Zollinger-Ellison syndrome. Very important discussion, guys. If you look into our entire discussion, what we actually did is we had a clinical scenario. We have not restricted ourselves to few options. We discussed wide possibilities. And my sincere request, you approach all the MCQ questions like this. That too, especially repeat topics, repeat areas. You need to know in and out about the repeat topic areas. And now with this idea, you get some important information about few concepts we have discussed here. And have them in your mind. I hope this in the short term help you to solve MCQs. In the long run, it will definitely help you in patient management. My good luck and best wishes to all of you. Thank you so much, guys.